Hi everyone, I hope you are well. Today in this video, I am going to discuss about one of the questions I get asked quite frequently, that do I really need CR in order to do full mouth reconstruction? Before I answer that question, let's look at some of the fundamental terminologies of occlusion. So one of the occlusion terminology is centric relation, and this is very controversial terminology because many people do not agree on the exact definition of CR, and at one point we had around 7 different definitions of CR. However, this is one of the accepted definition of CR, which is in Glossary of Prosthodontic Terms. References that below. CR is also known as retruded axis position, such as RAP. So if you're reading papers and if paper is mentioned, RAP is the same thing as CR. So let's look at this definition in more detail and why people are so bogged down into defining CR. So if you look at this definition, the first thing is that the position CR is independent to tooth contact. It is very important because teeth have different shape and sizes. You change restoration, and that's why there is chances that you are changing patient's occlusion. And because CR is teeth apart position, where teeth are not contacting when you're recording CR, teeth have no influence on CR, and that's why it is important for us to know that position. The next term which is used in definition is that it's the anterior superior position. Now this is the term many people disagree. There are a lot of controversies, but there is no way for us to know clinically when you patients in the dental chair that you have achieved CR, because you cannot really see the X-ray vision, and you may be able to do MRI, do CT scan, but it's quite advanced and you really don't want to put patients through all that if you're trying to figure out their first point of contact or something. So it is quite theoretical, that is anterior superior position, because no one would know when you're recording CR. The other thing the definition says that it's purely rotating movement, and we know that when mandible is in rotation, it works in the hinge axis, and rotatory movement is very predictable movement. When patient's mandible starts translating, that's when you start having other issues with the TMJ capsules and all that comes into play. But when it's rotating, it's much predictable position, and that's what the last 3 words are, that is a repeatable reference position, which means that there is very rarely patient's CR will change when they grow old. So if you are assessing patient's CR when they are 20 and when they are 60, it should be very similar. When I say very similar, because you can get arthritic changes in the TMJ and that can affect the CR as well. But technically or clinically speaking, the difference is not much. And that's why when we are doing full mouth reconstruction, I prefer to restore patient in CR, because I can go back to the same position again and again, although it may not be exact CR position because you cannot confirm. But if I know that I have a particular method to achieve CR, in that patient, I will be able to get repeated position, which is the same position. Because once you're doing full mouth reconstruction and once you're restoring whole arch or upper and lower both arches, you lose teeth as a reference. So you cannot use teeth as a reference when you're doing full mouth reconstruction. Yes, you can start doing quadrant dentistry, so you can just restore front teeth, leave the back teeth as it is, then restore the back teeth one quadrant at a time. It becomes quite challenging and cumbersome, but also by reorganizing, what you're doing is, as we discussed in previous video, that gives you a lot of flexibility. By increasing OVD, you are giving a lot of restorative space for yourself, and you can restore patient's teeth without damaging patient's teeth. So I would like to take advantage of that, and that's why I prefer to reorganize, and when I'm reorganizing, I am reorganizing patient into CR or CO. So what is CO? Centric occlusion or retruded contact position is the position when patient is in that hinge axis, and then with patients coming and they're closing their teeth, the first tooth contact while patients are in that rotatory movement is called CO. So if you imagine there is a hinge and then the back teeth touches first usually, and then the jaw moves forward and the front teeth gets in contact. So you have two different positions. The first position is when jaw try and contacts the first tooth, usually it's at the back, and then the jaw slides forward and then all the teeth gets in contact. So the CO is that first point of contact when patient is in still going from centric relation to centric occlusion. Occlusion is a little bit controversial term because it's not really occlusion, it's a point contact. And that's why people get confused between centric occlusion and maximum intercuspation. Centric occlusion is almost like a point contact unless you have done reorganization and you've done or full mouth reconstruction, and now patient's CO is equal to MIP. So when patient closes, they close all the teeth together. There is no slide because you eliminated the slide by doing full mouth reconstruction. The maximum intercuspation position is, we all know, when you ask patient to bite closely and all the teeth mishmashing really nicely, and that's called maximum intercuspal position. And this is the position we use most often in our day-to-day practice. So I hope that makes it a little bit more, you understand why I use CR position. So my top 3 tips from this video is that A, yes, I do use CR position when I'm doing full mouth reconstruction because it makes my life easy and it's a repeatable position, so I can go back to again and again. Remember, the CR is a tooth apart position, so teeth are not in contact. So if you are using mounting, if you're recording CR, make sure the teeth are not in contact. If teeth are in contact, by definition, you are not in CR. I personally restore patients from CR to CO because if I'm not sure of a patient's adaptive capabilities, then I would limit myself in restoring patients in CO, because when patients in centric occlusion, and then if you restore all the teeth in that centric occlusion, you're not asking patient to adjust too much, and because of that, there is much easier that patient will be adaptive to that height. If you're increasing patient's OVD, there are studies which shows that if patient has teeth, there's no reason why you cannot increase OVD as much as you want. But if patients have TMJ problems, then you want to limit increasing your OVD. So I hope you found this video useful. In the next video, we are going to discuss about Lucia jig versus leaf gauge, because if you want to record CR, you need some sort of deprogrammer, and these are the 2 most commonly used deprogrammer. So in the next video, we are going to discuss about these 2. I hope you found this video useful. If you have, please share this video with your friends and colleagues. If you have any questions, please drop me a message or go to my website www.drdevangpatel.com.